Welcome, I'm so glad you all could join me. I'm Chava and you're watching Ask a Midwife. Hello everyone, I'm Chava Ben Sion. I'm a midwife and I'm the creator of Ask a Midwife, these educational videos for folks all over the world to teach a little bit more about midwifery, about pregnancy, about childbirth from my perspective as a midwife of over 20 years. And I hope this is informative to you. Today we're going to be speaking a little bit about water breaking and the whole idea behind what's called the amniotic sac opening, the water's releasing. It's also called rupture of membranes, which is a little bit more of a technical term, a little bit more of a medical term. And in my opinion, as an English lover and writer, a little bit more of a violent term. But in terms of how that's referred to in the books and the literature, rupture of membranes is the technical term. My waters broke is a common term. The amniotic sac, the waters released, is a more kind of gentle term, but either one is fine. But what I'm going to be doing today is I'm going to be explaining what is actually happening when the waters break, when the waters release, how to tell if your waters truly have released, and what to do about it. So what I'm going to show you right now is this is a model of a placenta, the amniotic membranes, the amniotic sac, which extends from the border of the placenta here and creates a balloon around the baby. The balloon is filled with water, with amniotic fluid, and inside of the amniotic sac is the baby, the amniotic fluid, and the umbilical cord going from the baby's belly button to the placenta and exchanging oxygen, rich blood, and waste products with the placenta. So that's the setup to our story. Okay, and what happens is throughout the pregnancy, the amniotic sac, the membranes, create a very strong protective barrier around the baby. The amniotic sac, the membranes are actually adhered to or stuck to the inside of the uterus. So they are flush with the inside of the uterus. In the end of pregnancy, the cervix, which is the opening of the uterus, it goes through some changes in preparation for the opening, which needs to happen in order for your baby to come out. So the dilating phase happens after the phase of effacement or thinning, or also called ripening, which is where the cervix starts to shorten and become more pliable and more stretchy. And so as that happens, we're familiar with, if we've read a little bit or taken a class, the mucus plug can come out. And also the water can break in early labor, but most likely the water will break, the waters will release in more active labor. Active labor is the phase of labor where there's a lot of cervical changes, a lot of dilating, a lot of opening. And in general, if the water isn't manually ruptured, or the waters haven't been released by like a doctor or a midwife actually physically opening the bag of waters, generally the most common time for the waters to release is right before the baby comes out. So in that last phase of labor where you're doing a lot of dilating, a lot of opening, that's the most typical time, most common time for waters to release. But nevertheless, waters can release anytime before the birth, before the labor begins, in early labor, as labor intensifies in that middle part of labor, that active phase, or right at the end. And actually, as a midwife doing a lot of out-of-hospital births, in my experience, I've experienced many, many times where the baby comes out of, the baby comes out in the water bag, in the amniotic sac, which is called being born in caul, which is, I believe, a Latin term for being born with a head covering, which is kind of an interesting thing. So actually, it's not as unusual as a lot of literature would have you think, in that if the waters aren't broken artificially, meaning with a little, it's called an amni hook. If the waters aren't ruptured artificially, a lot of times the water won't break until the end of labor when the baby's coming out, and sometimes not at all. Sometimes the midwife or doctor has to physically break the water when the baby's head comes out so that the baby will be able to take his or her first breath. So in my practice, we have a lot of folks who call at the end of the pregnancy thinking, I think my water's broke. That's a very common, question. And it's one of the reasons why I wanted to bring you this video, in hopes that probably if it's a question in our practice, it's a question for many of you, and that maybe it's your first time, or your previous birth you'd never felt your waters break. Maybe they were broken for you. Maybe by then you had an epidural and you didn't experience what that felt like. You weren't able to really perceive what that felt like, physically breaking, but also you weren't able to really understand what was actually happening. So in this video, my hope is that you'll come away from watching it with a little bit more understanding of what is actually happening in the body when your water's released, when the amniotic sac opens. Okay, so this is a model, but in reality, it's not too far off from what's actually happening, in that the membranes are no thicker than like a balloon. And actually, when you examine the membranes after the placenta is born, you'll see that the membranes are actually very thin, which is interesting because they hold so much pressure all throughout the labor, all throughout the pregnancy. The baby's moving, there's water in there, there's lots happening. Mother's moving, there's lots of things happening, and the amniotic membrane is strong enough to withstand all that pressure, all that PSI. So one of the experiences of the water opening is a feeling of a pop and a gush. It feels like a sound. Like a lot of women have said, well, I heard it. I heard it pop. And that is something that's universal. I've heard, many women explain for many, many years now that they have this feeling, or if you've experienced it before yourselves, there's almost like a sound, followed by a pretty sizable gush of water. Now it depends on a few different things. How much water is going to come out? How much fluid? Is it that the baby's head is so low that a lot of the fluid is still trapped behind the baby, right? The head in the pelvis acts like a cork, and it prevents a lot of that extra fluid from coming out. So it might be that there was some fluid collected around the top of the baby's head, which came out when the waters opened, and then the baby kind of came down into the pelvis and blocked the rest of the amniotic fluid, which will come out when the baby's born in a flood of fluid after the baby emerges. So that could be if there was quite a lot of water and the baby was still high, you might have a larger gush. It just depends. So that could be a cup, a half a cup, but a sizable amount to where you're going to have a feeling of having saturated whatever you're sitting on, saturated whatever you're wearing. It's common to get a phone call or to get a question like, hey, I'm not sure if my water's broke. I got up and I felt something kind of slide out, and I wiped and it was a little bit wet, or my underwear looked a little bit wet, or there's a lot of questions surrounding the amount. And in my experience, when there's not a lot of it and you're not sure, my experience is that in most cases, it's not the amniotic sac. It's not the water. And this happens every month. We have a number of different women, a number of different clients who feel like, I think my waters have broken and I'm not sure. And so there are a few ways to determine if the waters have broken, which I'll mention in a few minutes. So there's a couple different experiences of the water breaking. It's a pop and a gush. For instance, you're sleeping in the bed, you get up to pee, it's 4 a.m., you go and you walk across your house, you sit down on the toilet and you sit down and you feel an internal pop, a sensation, followed by a bunch of water. It kind of feels like you're peeing, but you're not in control. And then following that first initial gush, there's often another, gush every time you move, every time you have a contraction, even if it's just a Braxton Hicks contraction, a toning contraction. Sometimes you'll experience a gush if you were to bear down, if you were to do a little bit of pushing, that you would have more fluid coming out. If you feel like your water might have broken, if you were to kind of squat down and push a little bit, you'd have more water coming out. So the idea behind the amniotic sac rupturing is that now there's a hole. Now there's a hole in the amniotic sac. There's an opening that's not going to necessarily, it's not going to close. The baby might seal it a little bit on account of the position, but that hole that occurred in the amniotic membrane is not going to close. It's now a hole, and so it will permit fluid to come out. Fluid will be able to emerge when you move, when the baby moves, when your uterus contracts, when you push down. There are different things that allow it to leak. And so if you've had a small amount of fluid, but now there's nothing, despite what you do, despite how much you're moving, and you went and had a bowel movement and you didn't notice any extra fluid, that's not very conclusive in terms of having, we generally assume the water hasn't broken if we're not seeing obvious signs of it having broken. The other way for it to break is with a small trickle. So, and in the same way that you'll continue to have water coming out, you'll continue to have fluid coming out, in that same way, even with a small trickle, and I'm talking not a pop and a big gush, but a small trickle, you'll still continue to leak fluid, even if it's just broken with a small trickle, maybe less drama, less fanfare, but definitely wetness. Wetness is continuing to come out. Now, this wetness is going to be different than profuse or a large amount of cervical fluid, cervical mucus, which also is part of the end of pregnancy. Anyone who's pregnant can probably attest to the fact that you've had a lot of discharge in the end, especially in the end of pregnancy. It's different than water breaking. Your amniotic fluid coming out is different than the cervical mucus. It's different than the discharge, the vaginal discharge of pregnancy. Although vaginal discharge in pregnancy can be very heavy. It can be very profuse. You're like, what is going on? And you're wearing a pad even because it's so much. It's different than the amniotic fluid leaking. But it's hard to determine what's going on, which is why, you definitely want to reach out to your care provider, definitely want to reach out to your midwife or your doctor, and just talk about it, like, this is what I'm experiencing. We have a lot of clients in our practice who do feel like maybe their water's broken. I would say probably 80% of the time we determine that the waters have in fact not broken. And we know this because in labor, as labor progresses, if there's usually like an actual moment where the water breaks, and then it's very obvious, and we look back and we say, okay, so that was the water breaking. The time before where you thought maybe you were leaking something and we weren't really sure, and we decided probably not, then we're confirmed that in fact it hasn't broken by the fact that in labor we do know the moment where it actually breaks. And it's most often with a lot more obvious signs, which is a palpable, of something you can feel, a pop and a gush, and it's very obvious. And it generally is combined with a contraction, it's combined with a trip to the bathroom, it's combined with some kind of experience of pressure. An amniotic sac will generally be stronger when the woman's diet has been better. So a poor nutritional intake can build a weak amniotic sac. Some folks are just more predisposed to having stronger sacs, and other folks their bodies are more predisposed to having weaker sacs, weaker amniotic membranes, so that they break more easily. Some folks who are experiencing a lot of cervical changes early in the last few weeks of pregnancy, rather than the cervix waits until the end, right before the birth, to thin out and open. If we have cervical changes happening, a few weeks before the end of the pregnancy, she might also be a little bit more likely to have her amniotic sac rupture early. It can also be that if she has a low-grade vaginal infection, even group B strep has been known to cause a weakness in the amniotic sac. So combined with poor nutrition, any vaginal infections that aren't necessarily even harmful to the woman, but can break down the integrity of the amniotic sac, can compromise the strength of the membranes, and you could see possibly the water breaking early. So in general, my advice to anyone who thinks that their water might have broken is definitely want to experiment with, does your position, does your activity, does a Braxton Hicks, does any movement changes on your part bring more fluid out? And if so, it's likely that it's your amniotic fluid leaking. If you felt some wetness but you're not really sure, but then no more wetness comes, it's likely that that it's not your membranes, that it's not your waters being broken. Sometimes women have bladder control issues that they don't even realize are issues in the end of pregnancy. And sometimes what's thought to be amniotic fluid is actually urine. So that would be another thing. Amniotic fluid does not smell like urine. It does not smell like discharge. It has a unique smell all its own, and I wouldn't be able to explain it to you here on this video what it does smell like, but I can just say that it doesn't smell like those other things, which are probably more familiar. It has a color. If it has a light, like a very, very light yellow color, like a straw color or clear, then that's considered normal amniotic fluid color. It should be basically clear. If it has particles of what looks like pea soup, yellow, green, brown particles in it when it does in fact break, that's a concern. It could be a concern. It's not always a concern, but sometimes if the baby has a moment of compromised oxygen, like let's say he moves inside the uterus, he presses on his cord for a second, he could poop inside the womb, and that's that yellow or brown or green matter that you're seeing in the amniotic fluid is called meconium, which is baby poop, essentially. And it's not always the symptom of an actual problem, but it's good that your care provider would know about that. So if your water breaks and you're seeing a color mixed in with the amniotic fluid, or you're not sure, then I advise you to contact your care provider, contact your doctor or midwife. They might even ask to see a photo. Oftentimes, if a client calls me and wants to report something, I said, send me a photo and I'll look and see the color. And that's really helpful because then I can advise them, okay, that looks fine, or that looks like meconium. Let's have you come in and we're going to give a listen to the baby and make sure that the baby's okay, or we're going to give other instructions. Okay, so water breaking with a color is always a reason to check with your care provider to see, if everything's okay with baby. So what to do if your water does break? First of all, look at the color. If there's an odor or a color associated with, if there's a foul odor or a color associated with the fluid that's coming out, you'd want to contact your care provider right away. You're not going to want to put anything inside your vagina after the water has broken. We're not going to introduce pathogens. We're not going to introduce bacteria. So, don't try to check your own cervical dilation. Don't have, intercourse or vaginal penetration. It would even be a good measure to take a shower or wash yourself after having a bowel movement after your water has broken, because what you want to do is you want to keep that area very, very clean so that pathogens don't enter the vagina. And it's very unusual after water breaking to have an infection. The less vaginal exams, the less interventions that someone has after the water has broken that involve putting something up inside the uterus. So vaginal exams, an intrauterine pressure catheter, an internal fetal monitor are examples of things that would go up inside that could introduce pathogens into the uterus. So once the water has broken, there's an opening, which is essentially in theory, a pathway or a passageway up into the uterus, up into the baby. And so we're just really, really careful about hygiene. We're really careful about creating a clean area and creating a clean space so that no extra bacteria can penetrate the uterus and compromise the baby or create a uterine infection, especially during labor. So that's the reason why once the water has broken, it's considered in most circles in a lot of, medical practices, as well as, standard obstetrical practice, standard Western medicine practice, and a lot of midwifery practices that we consider the clock has started ticking. And as much as that's not conducive to a relaxed feeling in labor, as the idea that you're on the clock doesn't help anyone actually, proceed with labor, feeling pressured. It's good to just know that once the water has broken, there's no going back. You're not going to be pregnant for weeks. We're talking about a normal, full-term pregnancy. I'm not talking about rupture of membranes that occurred at 30 weeks or 32 weeks, where those would require different management to try to possibly keep the woman pregnant, keep the client pregnant for longer, to gestate the baby longer for a better chance of survival after birth. However, we're talking about in a normal full-term pregnancy. Once the waters have broken, we would really like to see active labor, which means she's having contractions, she's dilating, things are progressing, ideally by about 24 hours. Now, every practice is different. Some practices want a client to start antibiotics to combat any potential infections. If a client has what's called group B strep, or the presence of that bacteria that we culture for at around 36 weeks, it might be more worthwhile to start antibiotics earlier. There are different management decisions that go along with the woman's water opening, but in general, we know that like labor should start within 24 hours, ideally. Sometimes we need to, help it along a little bit by some natural methods of labor stimulation. We do lots of different things in our practice, which are not as interventive as a medical practice would be, but they're quite effective, especially if she's full term, especially if her waters have released. The body knows that it's time, and sometimes it just needs a little help getting kicked into labor. But we use our individual management with every client. So we don't give the same advice to every person. We give individualized advice, which is one of the tenets of midwifery care, is that we give special, tailored advice, obviously within our practice protocols, but we give special advice unique to each person's situation and their needs and their history and their considerations, their even maybe their personal considerations, like maybe their fears, the things that they're concerned about, and the things that they want. Like some folks would be really comfortable just watching and waiting for labor to begin, and other folks would like to stimulate stuff. So we take everyone's own situation into consideration with regard to the waters being ruptured. But in general, as a takeaway, I would say that lots of folks think their water might have broken. A lot of those folks find out that, in fact, no, their water hasn't broken because, in fact, they do experience what it really feels like later on in labor. If the amniotic sac has ruptured, you're going to experience intermittent yet consistent leakage. So it's not going to be urine. It's not going to be cervical mucus or vaginal discharge. It's going to be a thin, watery, and profuse amount every time you move or, bear down, or you have a Braxton Hicks contraction or an early labor contraction. You're going to notice that things are going to be leaking out, and you won't be able to. It's not like peeing where you can physically stop it, right? It's just going to be coming out. You can wear a pad just to see what color it is, but in general, try not to allow, if your waters have been broken for a while, we don't love you would wear a pad because it can harbor bacteria. So anytime you can kind of go without, like if your water breaks and you're around your house and you can just kind of like sit on one of those absorbent pee pads, we call them Chuck's pads in our practice. They're the blue pads that you see that, absorb. You can sit on those. You can just, be free with no underwear or whatever. I mean, obviously, if you need to wear a pad, you can, but ideally, you don't want anything increasing the chances of infection. Hands out, no intercourse, no checking your own dilation. It's better to just leave well enough alone. In labor, we do some vaginal exams as necessary, and maybe you might be wondering, well, if you're not supposed to put anything in there after your water breaks, then why would you do so many vaginal exams? The answer is you shouldn't do so many vaginal exams if the water's broken. The only reason you would want to do a vaginal exam is if there was information that you stood to gain from the exam that's more valuable than not doing the exam at all. So if we get information from checking about management, like, okay, let's change your position. Okay, let's send you home. You're not really in labor. Okay, let's help you progress. Oh, look, you're giving birth. Let's get you ready for delivery. Those are the kinds of things that we, in terms of making a management decision, or the information is valuable to us. And in that case, we try to really minimize the amount of vaginal exams that we do. We try to always use, a sterile technique. So we're going to use sterile gloves, and we might even use some betadine to cleanse the area and just really make sure that we're protecting her from any, pathogens going up. But in general, we're really choosy and really picky about when we're going to do a vaginal exam on all clients, and only with consent and only with talking with the client about, okay, this is why I think a vaginal exam might be worthwhile, and what do you think about it? And so that's a conversation that you should really feel empowered to have with your care provider. And I have another video where we talk about communicating with your care provider, and it's kind of a summation, a collection of all the things that I've experienced over the years that are helpful to remember and to bear in mind and to utilize when you're communicating with your care provider. And it can be a little bit intimidating sometimes to ask for what you need. So if you want to check that video out, I encourage you to do that. And in general, you can always comment down below. I'm sure I haven't explained everything about water breaking, but I feel like hopefully with this video and some of my other videos, you might be able to gather enough information to make a good decision for yourself and make a good decision about, when to go to the hospital and all those, or when to call your midwife in that case. So in the end, I'll just show you again that this is the baby inside the amniotic sac. Okay, and we have inside the amniotic sac, we have the amniotic fluid, we have the umbilical cord. And what happens with the water breaking is this is sealed, all right, and something will happen inside the uterus. A little weak spot might form, and as a result of pressure from the top of the uterus squeezing down, and in a combination with the lower part of the uterus, the cervix kind of being drawn up and thinning, the water there'll be a hole formed in the amniotic sac, and then it'll open, and then the water will come out. Okay, and then the other thing that I forgot to mention, and hopefully you're still watching, is that once the water is out, there's no such thing as a dry birth. In that, a lot of folks think that once the amniotic fluid has released and the water has left the uterus, then the baby's in there with no protection. All right, that's very not true. And any midwife who has helped women throughout their entire labor knows that the water might break, and then there's tons more water left over. The body continues to produce amniotic fluid for the baby, because the amniotic fluid is one of the things that's protecting the cord, the umbilical cord. It's protecting from pressure. So the fluid acts as a cushion for potential pressure on the umbilical cord, which is really great. So the body keeps replenishing. So just drink a lot, eat really well, eat protein, eat good complex carbs and protein, and drink a lot, and your body will just continue to replenish. So you'll continue to leak. So that's another thing that worries folks, is that when your water breaks, they're thinking, oh no, now the baby has no water, and that's going to be a complication. I'd just like to touch on one more thing that I think it's really important for everyone to know, is that the water breaking doesn't necessarily mean you're in labor. It doesn't necessarily mean you need to rush to the location that you're going to give birth in. It just means that you ought to let your care provider know and discuss options as far as going forward. Would it be worthwhile to stimulate labor? Is it better to watch and wait? What's going on with the baby? Are there any other risk factors and things like that? But just be mindful that the water breaking is a signal that things have begun, but not necessarily enough so that you would need to go to the hospital or your birth center yet, or call your midwife. Okay. I think that's it for now. I thank you so much for watching. I really appreciate you tuning in. I'm hoping to bring a lot more educational videos for you and to you. And I hope you enjoy. Please leave any questions down below and I'll try to get to them. And tune in for more. Thanks so much for watching Ask a Midwife. Bye!